Okay, so let's talk about blood pressure. Blood pressure is the force that's exerted against the inner walls of the blood vessels. So it's the force that the blood exerts against the inner wall of the blood vessels. Blood pressure is highest when the ventricles are contracting, and it falls when the ventricles relax. So systolic pressure is the maximum pressure, and this is when the ventricles have fully contracted. So this is the max pressure. And that's when the ventricles are fully contracted. And the diastolic is when the ventricles are relaxed and not pushing blood out. So normally we see our blood pressure as 120 millimeters of mercury over 80 millimeters of mercury. And this is the systolic. The top number is the systolic, and the bottom number is the diastolic. All right, we can feel when the arteries are expanding due to a higher blood pressure and relaxing with a lower blood pressure, and we feel that as the pulse. So the pulse is when the blood vessels expand, we feel the bump, and when that little bump goes away, that's when the ventricles are relaxed. Radial artery and the carotid artery are the two most common places we see people take the pulse. Pulse is usually measured in beats per minute. Brachial artery is something you'll do for the lab. You'll need that. And then if someone, say, had an issue with, maybe some bleeding in the leg or damage to the leg, we would maybe take the posterior tibial artery to make sure they still have blood flow through the leg. All right, factors that affect blood pressure. We have, and this is the whole pressure and volume, that if you have a closed container and you increase the volume of material in the closed container, pressure will go up. Or if you make the container bigger but don't increase the volume, pressure will go down. So blood pressure increases due to blood volume increasing. And this could be, blood volume increases happen when we add, say, more water, where we hyperhydrate, or when people add red blood cells through blood doping. So the amount of material in the container goes up, that makes the pressure goes up. Heart rate increases. This is because we're pumping the material through the system faster, and we pump it into the arteries faster, and that'll make the blood pressure go up. Okay, so we said as the heart rate increases, the blood pressure increases. Stroke volume increases. Stroke volume is just how much blood is pumped out with each ventricular contraction. Okay. Blood viscosity, as the blood gets thicker, so we lose, gets thicker, it gets heavier, and that's going to increase blood pressure. Think about if you had a balloon filled with, say, air. It's pretty light, but you fill it with water, which is a more viscous material, it's going to be much heavier. And then peripheral resistance increases. Peripheral resistance causes the volume of the container to shrink. So peripheral resistance is when the blood vessels, say in the arms, legs, hands, and feet, constrict. That's going to increase blood pressure, because now you're trying to pump the same amount of blood through a smaller area, and that's going to increase blood pressure. Okay, control of blood pressure. We're really just going to look at the two things on the outside here. So when blood pressure decreases, we have a decreased blood pressure. That causes our sympathetic nervous system to secrete epinephrine. Remember epinephrine, one of those fight or flight hormones, will cause the heart rate to increase. So we are increasing the heart rate, which increases cardiac output. Cardiac output is stroke volume times heart rate. Okay. And so it gives you a milliliters per minute. Gives you a milliliters per minute. How much blood are we moving through the system in 1 minute? Because stroke volume is milliliters per beat, heart rate is beats per minute. So we get rid of beats and we've got millimeters per minute. Okay. So we increase cardiac output, which means we're putting more blood into the system, and that will cause blood pressure to increase. The other one I want to look at is this vasomotor center. Remember we talked about the vasomotor center and the cardiac control centers and respiratory control centers all in that medulla? Well, the vasomotor center can set a signal to the peripheral blood vessels that they should constrict, make themselves smaller. And like we just talked about, when those peripheral blood vessels get smaller, you increase the peripheral resistance and you can increase the blood pressure. Okay, and this is another situation where we want to lower blood pressure. So we take the cardiac output, so the cardiac output increased for whatever reason. So blood pressure went up. And because of that, we have baroreceptors. And these baroreceptors are in, remember the aorta, how it comes out of the heart and goes around? Baroreceptors are here in this aortic arch, and also in the carotid sinuses. These are stimulated to say, hey, blood pressure is going up. And they send a signal to the medulla, to the cardiac center, to say, hey, blood pressure is going up, this is a problem. The cardiac center can increase its parasympathetic impulses to the heart. And remember that the parasympathetic impulses are always going to the heart, always going to the SA node to make the SA node slow down, because the SA node would be beating at rest at like 80 beats per minute. But there's always this parasympathetic inhibition that's happening there. So the SA node is inhibited even more than usual. That decreases the heart rate, and then a lower heart rate means you lower your blood pressure. All right, another situation. is when we have rising blood pressure. Get the same idea that this stimulation of baroreceptors in the aortic arch and the carotid sinuses send another impulse to the vasomotor center in the medulla. And the medulla the vasomotor center can inhibit the sympathetic impulses of the arterial walls. And when that happens, the vasodilation increases. So the arteries get bigger. Because normally those sympathetic impulses are causing the blood vessels to constrict. So instead of having an arteriole that's this big, now your arteriole is this big. That's an exaggeration. But you can fit a lot more blood into this one than you can into this one. So vasodilation leads to increased volume of your container, which decreases your peripheral resistance, and the blood pressure goes back to normal. Now, this is how we're going to talk about how blood vessels, or how blood gets back to the heart through the venous system. Because remember, the venous system is under low pressure. So one of those ways that the blood gets back through there is through skeletal muscle action, which is what we see in this picture. Skeletal muscle action. And that's what we see here. That when the skeletal muscles contract, they're going to squeeze the veins, and that's going to force the blood up into towards the heart. Another reason is, well, there's just these valves. The valves prevent blood, once it's being squeezed through, from coming back down. Remember, the force of gravity is higher than the blood pressure there. We also have venoconstriction. So the veins can constrict a little bit. And then a big one is breathing. Because as we breathe, well, this will be a picture of our thorax. As we breathe, our diaphragm, which before we breathe in is up like that, we take in a deep breath, the diaphragm lowers, pushes into our abdomen. When that happens, it decreases the pressure in our thoracic cavity. So as that pressure goes down, the blood vessels, like the inferior vena cava, for example, can force their blood up towards the heart because the pressure in the thoracic cavity dropped. Now, when we let out that breath, our diaphragm goes back up into the thoracic cavity and the pressure increases. So every time we take a deep breath, the blood can move towards the heart. And this is one of the reasons why doing those deep breathing exercises, so sort of meditation or yoga or Pilates or just really any exercise, will help you to bring more blood back to the heart. Central venous pressure is the pressure in the right atrium. Okay, it's pressure in the right atrium. If we have like a weakly beating heart, so our heart is not beating very strongly, central venous pressure goes up. And that means the blood in your peripheral veins is going to accumulate there because we're not getting the blood out of them. Okay. So we can take measurements of this. And as this central venous pressure increases, we know that the heart is either weak or getting weaker. So it could be a sign of damage to the heart tissue, something like that. Okay, pulmonary circuit. Pulmonary, and this is stuff we've already gone over, so I'll be quick with this. Pulmonary circuit is how blood goes from the heart into the pulmonary trunks, the left and right pulmonary trunks, and into the lungs. In the lungs, there's many capillaries that will do the gas exchange. So carbon dioxide will leave the blood, oxygen will enter the blood, and then the oxygenated blood will now go back to the heart through those pulmonary veins. Okay? So, and the pulmonary veins deliver it back to the heart. And that's the pulmonary circuit. So just to reiterate, start with the pulmonary trunk, goes into the left and right pulmonary arteries, goes out to the lungs, comes back to the heart from the lungs through the left and right pulmonary veins. The systemic circuit is just the, here's my heart, goes from the heart out to the tissues of the body, and then back to the heart. That's a systemic circuit. We've already talked about that. Okay, it's really just the aorta and all of its branches. Major blood vessels associated with the heart. Well, we've got the right common carotid. Well, actually, hold on. I just want to point out a couple of things. Here's that aortic arch. Okay, there's the aorta. Remember that the first two places, which drawing in here, it's not quite there, to get blood are the left and the right pulmonary, or the left and right coronary arteries. The heart gets the good blood first. And then there's three branches off of the aortic arch. The first branch is this one called the brachiocephalic artery. The brachiocephalic artery will further divide into the right subclavian artery, which goes to the right arm, and the right common carotid artery, which travels up the right side of the neck into the head. The second branch is the left common carotid artery, and that one goes up the left side of the neck to the left side of the head. And then the third branch off of the aortic arch is the left subclavian artery, and that one goes to the left arm. So those are the major branches that we have to know for that. This is just more of a reference. We're not going to talk about all of these. We will talk about the, let's see, well, we already talked about these ones. Okay, so we already got this one. And we will talk about the renal artery when we do the kidneys. And well, that's it for right now. Oh, common iliac arteries, we'll talk about those. And a couple more we've got to do. So here are those major branches. I'm just going to circle the ones we're going to talk about. These are the abdominal. This is the branch of the aorta after it has descended, and now it becomes the abdominal artery. Hepatic artery goes to the liver. Renal artery goes to the kidneys. Common iliac arteries are going to go to the legs. And splenic artery is coming from the spleen and other places. Or going, I should say, to the spleen and other places. Okay, this is a hepatic portal vein. Hepatic portal vein drains one set of capillaries and that lead to another set of capillaries. The set of capillaries it drains come from the splenic artery and the mesenteric artery. Okay, and those are bringing blood from the stomach, from the spleen, and from the intestines. So material coming from the stomach, spleen, and the intestines is going to be nutrient rich because stuff's been absorbed there. So this material that's passing through the liver that's nutrient rich, some of those nutrients need to be processed by the liver. For example, glucose will be converted to liver glycogen so it can be stored. So glucose is converted to liver glycogen so it can be stored in the liver. But another thing is that there's bacteria coming from, say, the intestines or the spleen. The spleen's a lymphatic organ, and there's bacteria coming from the intestines that need to be processed by the liver. This way, we're not circulating, and there's specialized cells in the liver called Kupffer cells. We don't really need to know that. But those specialized cells are white blood cells that break down the bacteria. Because we don't want all this material coming from the stomach, spleen, and intestines that's full of bacteria to be going all throughout our body and causing damage. So instead, that blood that's coming from there gets processed in the liver, and the liver can kill off the bacteria. And then that nutrient-rich, albeit deoxygenated, nutrient-rich and hopefully bacterial clean blood can now go back to the heart to be circulated. Okay, clinical application. So you should be able to do a couple of these for the test. But it's not, don't memorize these. Don't try to memorize what each of these is. Instead, understand what you're seeing and what you're not seeing. So a ventricular fibrillation is the most serious cardiac problem because you're not getting good ventricular contractions. And you can tell this because, look, you don't see any QRS waves. So there's none of these in here. We don't see any of these. So that means the ventricles are not depolarizing. They're just rapidly depolarizing, but not in an organized way, and maybe not even together. So the person's having a heart attack here. So this would be a way how, if you were to get this question on the test, you don't have to name this as a ventricular fibrillation, but you should at least be able to say, hey, there's an issue with the ventricles with this, because there's no QRS wave or complex. Tachycardia is a rapid heartbeat. This tachycardia could be because someone's having a panic attack, or it could be someone went out for a run. So it's a rapid heartbeat. Tachycardia is rapid heartbeat. Atrial flutter is, it's kind of like an atrial fibrillation, but atrial flutter is more organized, less random than a fibrillation. So this flutter means the atria are kind of in the circular pattern of depolarizing. So instead of just depolarizing once, they're being depolarized over and over and over in a circular pattern. This could be just a heart defect. It could be damage to the heart, in that instead of the atria just depolarizing once, they are just going to depolarize over and over. And it's more how that syncytiny can contract or can feed back on itself. It's a circular loop of the atrial depolarization. This one would not be as bad because you're still getting a you're still getting a QRS complex. And the other thing to remember is, even though the atria are not depolarizing in an organized way, remember that 70% of the blood that's pumped, or that is passed from the atria to the ventricles, just passes through passively. So it doesn't even really, well, it does matter, but your person could still be okay with an atrial flutter because most of the blood is just passing through passively anyway.